very distinguished professor from Italy. Everybody knows him, who is on the field, who is going to talk to us about myosin inhibitors. Professor Cecchi.
Thank you, Georgos, for the invitation. I wish I could have understood a little bit more about the talk and above all, of the discussion. That could have been really very interesting. Anyway, let me talk a little bit about these new drugs that are already, with us. But let me just remind first that if you see this patient, for instance, you realize that there are several possibilities of LVH. It may be localized, may be distributed, they may be massive, like in this case. And in fact, this patient, he had some obstruction, but if you see it correctly, it was a kind of restrictive kind of hypertrophic cardiomyopathy because the chambers were really very small, almost invisible on the right side. However, at the same time, you may really have a very, very little hypertrophy, and this is the man that actually drove us to have this kind of study where we demonstrated that if you do an exercise test, you may provoke really a high gradient, a lot of mitral regurgitation, and from that patient, we started the study with Barry Meron. But I believe that we have novel therapies, but we already have very important therapies that really make our patients feel better and have a better survival. So in the last 20 years, we use nadolol and azoparamide, and we have a strong effect with these drugs. But however, we have these new drugs that are really somehow, fantastic in terms at least of reduction of left ventricular outflow tract gradient. But let's see, what we got so far, and above all, the real-world studies. So basically, what happens in hypertrophic cardiomyopathy, and this is coming from our studies from myocardial cells taken out during the myectomies. You see that there is an increased myofilament calcium sensitivity, and which, happens to be at the cost of tension generation. So it's like to have a Ferrari in your house instead of a normal car that needs a lot of petrol, okay? And this is one of the possible reasons why then these hearts, are going to have, energy proliferation, apoptosis, myocardial dysfunction, hypertrophy, and fibrosis. Maybe not all of them, but, for sure, some of them. So what happens? If we have this kind of sarcometic dysfunction and excessive energy consumption, what we can see as cardiologists is the hypercontractility. So this is the basic concept, to me at least. And this is due to excessive myosin and actin interaction. We now imagine that there are these myosin heads, that interact more with the actin. But let's see what these two new drugs are doing, and they actually are a little bit different. Mavacamten stabilizes myosin into a super relaxed off state, decreased HPA's activity and slowing of interaction of myosin with actin. Aficamten binds to a distinct allosteric site on the S1 domain of myosin. It reduces ATPase activity by slowing phosphate release, stabilizes a weak actin binding state, and they have a different pharmacokinetics, much longer in MAVA and shorter in AFI, with an easier interruption of the consequences of the drug. So when you give such drugs, this is the effect. You have hypercontractility on the left, that is reduced, at the bottom. And as you can see, the gradients, if you measure them, of course, they are reduced. What is missing here, let me say, the black hole of all these studies is the fact that nobody takes care of mitral regurgitation. And mitral regurgitation can be a great component of the symptoms of the patients. and of course of the consequences of the fact that the left atrium dilates. So this is a very, that's a black hole in our understanding of what's going to happen. What can happen is also in rare cases, not in all, of course, is the dramatic change and improvement in ECG, which, at least for me, I don't understand it purely, because why is this happening? We don't know exactly. I don't know if Bill McKenna, who studied ECG since the first years of his investigations, would be able to give an explanation. But let me go on with the long-term results of trials. So we already heard before from Dr. Gossios that we have on average a reduction in resting gradients and provoked gradient. And above all, what is surprising, and that's one of the key messages that really we have, how can it happen that proBNP is reduced to such an amount on average in these patients? So that was really one of the key messages. Troponin and proBNP, the really reduction. You have already seen this slide, the long-term Valor study, which was an amazing, study, even from when it was, thought and then put in practice. However, the long-term results see that most patients who were in class NIA 3 and 4 really had only a very few of them remained in class 3 or 4, but most of them improved by 1 or 2. However, altogether, if you put them together, 15% and 6% that decided to proceed with SRT, you see, they still remained SRT eligible. So we have about 20% of patients that nevertheless still were, they had an indication either to myectomy or to alcohol ablation. And, you've already seen this, that is on the average, as soon as the placebo was stopped and patients got the mavacamten, all the data, were similar. So the gradient went down, and as well as proBNP and troponin. Aficamten has the same results, even better in a way, for VO2 max. So surely these kind of myosin inhibitors, we're going to have an improvement both in VO2 max and the reduction as well of the gradients. However, let's see a kind of meta-analysis of these clinical trials done both with MAVA and for aficamten. Total 900 patients, and we would say these authors concluded that both drugs were generally well tolerated. However, the patient on MAVA had higher rates of treatment interruption due to left ventricular ejection fraction reduction. And as you see, when we talk about arrhythmias, atrial fibrillation was much more frequent than in the placebo group, up to 11% versus 4%. And heart failure, per patient years, and 1.7 heart failure per patient year versus 0 in the placebo. So we have to be a little bit careful. Of course, the comparison between the two drugs are also depending on the fact that aficamten has no long-term study so far. However, if you compare them and do a meta-analysis of what are the drugs that are really efficacious in reducing the left ventricular outflow obstruction, we have beta blockers, as you can see on the resting gradients, not really the calcium channel blockers, disopyramide for sure, and myosin inhibitors as well. And the same, more or less, with provocable gradients, although here calcium channel blockers may be really more efficacious. But let's go and see the results of the real world. Should we expect more problems? And let's start with the fact that, for instance, in the studies and in the trials, the mid-ventricular obstruction, which represents more or less 5% of our patient population, are not reported. So this question was not answered. And this is, for instance, a couple of cases that were presented and published by Liacrotti and the group of investigators that I trained in Milan in auxologico. Everybody probably knows Liacrotti for the channelopathies studies and her experience in Brugada and long QT syndrome. They just published with Peter Schwartz a paper on the New England. And as you can see, it can go from a gradient of 77 millimeter of mercury down to 11 millimeter of mercury in these two patients. So for sure, we have this good news in the real world experience. But then let's see what has been reported so far. This group of investigators reported mavacamten for at least 6 months in their personal experience. So the gradient went down from 105 at the initial evaluation down to 24. So not completely resolved on average, okay? And the ejection fraction was only mildly reduced. And if you go and see what happens later, that the patients with obesity were less likely to have symptomatic improvement. And as well, and they had something like surprising, 47% of these patients they followed were obese, 47, so half of them. This really gives you the quantity of obesity that is affecting the American people. And anyway, there were no differences in mavacamten effectiveness for white versus non-white. But at the same time, you see that 28% of the patients had no change in NIA class. So 1/3 of them. So this is the first in 2024 real world report. However, the worst scenario is when you have really a dramatic change in ejection fraction from 73 in this case to 40%, and then, after a few weeks, when the drug was discontinued, of course, they returned to almost the same time. This takes some time, by the way, okay? And let's see what can be the consequences. Mark Sherrid, a colleague that we all know very well, reported, for instance, an apical ballooning and cardiogenic shock. So you have to be careful. Anyway, this may happen. But above all, what I want to report to you is a paper that is going to be published, but is already present on PubMed, of a large, very large quantity of patients treated with mavacamten. And you see we have 1,500, more than 1,500 patients from 21 US centers. And look what happened to these patients. 5% had a new atrial fibrillation, which they had not in the past. In 39 of them, it was recurrent. And you had a systolic dysfunction greater than, with ejection fraction less than 50% in 8%. And 70% of them, they had a concurrent atrial fibrillation. Of those, 21% had congestive heart failure, and 0.6% had a cardiogenic shock. So it's not really totally safe to use this drug unless you really are careful about, following your patients and, giving the right dose to them. 5 deaths were reported, 4 cardiac and 3 of whom sudden. But above all, you had 7% of hospitalization due to AF, HF, and which were complications related to the mavacamten. 12% had to have a temporary discontinuation and 7% permanent. So I believe that these results are impressive, at least to me. They give you some warning about, how to use these drugs. And in our colleague, Nicola Maurizi, who's now in Lausanne, he observed a hypertensive crisis in one of the patients. As you see, the patient started with 145 millimeters of mercury blood pressure. Then when he started MAVA and the gradient went down, he had a hypertensive crisis that resolved after antihypertensive drugs, strong hypertensive drugs were added to the therapy. Then everything was fine. But you also have to be careful about that. So if we compare, the trials with the real world, you have that the trials, we already know what happens, and I will repeat that. But let's see what happens in the real world. That not all, but most patients improve, but obesity is a limitation. that the gradient reduction is clearly observed, that we have the improvement of the quality of life, above all in the first months, and the satisfactory safety profile was demonstrated. However, the titration must be cautious compared to trials. And let's understand that most patients were older and in class 2 NIA. But AF and systolic dysfunction are the most common cardiac complications that we have to be absolutely aware, and we have to, if needed, we have to possibly even prevent them. In fact, if you see from the advice that the Swiss Medical Association gives is the fact that you have very common problems with MAVA is dizziness, 21%, heart failure and systolic dysfunction, and I would add, at this point, even atrial fibrillation, which may occur. This may depend on the cytochrome variants, which in Europe and in Italy are absolutely mandatory. So you understand that 5% of your patients will be slow metabolizers. So they might be responsible of all the consequences that the real world data I showed you before. However, this has to be absolutely taken care of. And pregnancy, of course, may be a problem. So going to my conclusion, about more than 10 years ago, we prepared this paper and we showed what can be a patient journey with a hypertrophic cardiomyopathy. You may start with no symptoms in a non-hypertrophic stage. Then you have the development of LV hypertrophy of different levels, as even Bill showed this morning with the troponin genotypes. Then you have the classic phenotype, where you really have hypercontractility. You see prevalence 75%, and the ejection fraction is greater than 65%. At this point, you may have just a basal obstruction or a provocable obstruction. And in these patients, very often, only half of them have symptoms, and usually there is no, or fibrosis is really very mild. However, there is also a stage 3, where you have, again, provocable or basal obstruction, but you also have moderate and severe fibrosis. And then you have the ones that we called end stage, and now we call here overt obstruction, where you have no more obstruction, or obstruction is lost. You have mitral regurgitation, you have severe fibrosis. So I would say that probably, to my opinion, myosin inhibitors are clearly indicated in stage 2, but you have to be very careful with myosin inhibitors, when you are in stage 3 and you have some fibrosis, you have mitral regurgitation, and the ejection fraction is just greater than 15%, but not really so. It's ready to really be lowered. So in conclusion, I would say that in the majority of patients, myosin inhibitors are able to reduce consistently the obstruction and even the mid-ventricular obstruction due to hypercontractility. However, a minority of these patients with severe mitral valve regurgitation due to mitral valve abnormalities might still need an invasive intervention, usually myectomy, to correct the mitral valve abnormalities. However, a careful follow-up is required for drug titration in the first months of treatment to avoid excessive left ventricular ejection fraction reduction, to avoid atrial fibrillation and heart failure. And in this sense, the cytochrome gene variant analysis is mandatory. They are now second-line therapy, but maybe first, although high cost is an issue and we have to take care of that. However, the results of long-term real-world data, as well as subgroup analysis like gene variants, are they important in this setting? Could they really give better results in this setting? We don't know, because we haven't got any information out from the trials. And the additional trials are needed both to understand what we need to do with children and adolescents with left ventricular outflow tract obstruction. In my final slide, as I was telling you this morning, the shared decision-making is an important issue so far. I believe that all cardiologists, instead of just saying we have a new drug, we have a fantastic new treatment, I believe we should be more calm, very cautious, discuss with the patient the options. Because, for instance, if you are a young girl with severe obstruction, with all the problems of pregnancy and forever treatment for life, I believe that we should always discuss this with the patients. And above all, we should not just use these drugs in each single center, but above all, refer, as it was suggested from the American guidelines, to discuss this with heart teams that would really suggest the best treatment options. And in this sense, unfortunately, this is not what is going to happen, for instance, in Italy, where, in each center, each region can decide who is able and is allowed to give this kind of treatment. In this sense, as I will tell you later, we created this association of patients and we receive everyday calls to understand, the options and to have information about this kind of drugs. Thank you very much.
Thank you very much, Professor Cecchi, for your talk and your word of caution about the drug, which seems that because it's easy, can be used very easily and to a sort of a very broad spectrum of patients. And we don't know exactly, actually, although you said that we need more discussion and you need hard teams, again, we don't know exactly who are the ones that they have to be excluded. It's a difficult, anyway. Do we have any questions? Professor McKenna, do you want to make a, yeah, I'm sure you would like to.
So, Franco, very nice, as always. This is a comment from no clinical experience of either of these drugs, or very limited. So, but reading the papers, and particularly clear in the aficamten issue of JACC, the majority of patients on aficamten do not feel significantly different, and yet some feel very much better. Everything else you can say is statistically different, like the changes in VO2. Those are very, very minor changes that it's statistically significant, but is it clinically significant? Maybe, but just. So question mark, one of the impressive things you showed is that in the longer term, there's actually patients, or in the follow-up studies, there's actually there are a number of patients who develop atrial fibrillation, heart failure, problems. Are these people who were initially successful on MAVA, or are these actually the group of maybe 50% who didn't have a dramatic change anyway? And so the natural history is just the natural history of their outcome, plus or minus MAVA. Do you follow the drift?
I believe that we have no data. As we said before when you were talking, we have got data from the trials, the single point data from the single patients, and also they just reported the complication, but not really whether, this was due just in patients who had really an excessive left atrial dilatation. So it is not clear, and we really would need, so this is impressive, as, I agree with you, because atrial fibrillation as a consequence may have, if you don't have anticoagulation, as a consequence might have even stroke. So strokes are not reported so far, but what is important is to understand that this may be a problem. So for instance, before giving MAVA or AFI to a patient who has already a huge atrial dilatation and some, atrial ectopic beats, frequent and above all in runs, I would really be careful and probably maybe even discuss before, what a treatment, to avoid that. But we have no data. That's what we can say. And this was a kind of surprise. So in one way, we thought that this was really magic, but in fact, in the long term, in real world, we also see problems.
So, one more?
Yeah, sure, yeah.
One other question, which I think I know the answer, and it's short, is do we know anything about the genetic background of who does and does not respond?
The response is no, unfortunately, and that's what we know we could really have in the next future.
It seems to me rather bizarre, actually, that you have 0% of atrial fibrillation in the placebo group. In this type of patients, again, that's a bit of a.
Well, this was in the trials. In the
What I'm saying, in the trial.
Trials are short term. So you
1 year, nobody to, none of them to develop atrial fibrillation. I don't know. It has a bit of a shadow there all over the place.
This is just a kind of meta-analysis of the trials. Okay, so these are the data that they presented us. I mean, so although we have really no real answer to that, I wish that let's so-called old investigators like Bill and I are, could have our hands on this data, in order to understand that to be better.
It seems a fantastic drug.
Yeah.
But apparently must be something there which is well hidden. We have to understand. And I'm afraid that we will understand that when we will start using it ourselves.
When I asked, for instance, not only the single pointed data, but also how many patients had, which degree of mitral regurgitation, it was not absolutely clear. So that's a black hole that we need to understand and fill.
Well, thank you very much, because you complemented very well the good things I said, but on the other hand, you provide a word of caution. That's always very important. And I think the key thing that you mentioned is careful patient selection. Yeah. A normal ejection fraction is not a supranormal ejection fraction. So it was a discussion we made in Greek mainly, and unfortunately you couldn't follow it, but it was that in our short experience with the 30 patients we've got, is that we picked the ones with the hypercontractile left ventricles. And the thing about the atrial fibrillation, you're making also a very good point that there are some people who have obstruction, but they are gradually developing this major left atrial dilatation, which is, to my eyes, an early stage of verging towards burnout phase. Although the ejection fraction is still preserved on conventional means, many of these people will end up having a reduction later on in life. So from the 30 patients we had so far, there was only one patient with new onset atrial fibrillation. And we need to also consider that how well tolerated that was, because a patient with obstruction and AF may be severely impacted, whereas with no obstruction, it might be much better tolerated as well. So it is an issue of
this is also important for atrial fibrillation. When it starts, you never know when if the heart rate will be too high or lowered. So giving up with beta blockers in this sense exposes to a higher risk of having very fast atrial fibrillation with a very fast heart rate. And if you have obstruction and if you have mitral regurgitation, you have a pulmonary edema almost for sure, if not cardiogenic shock. As we saw, we don't know why they went into cardiogenic shock, whether for ballooning or for atrial fibrillation at a high ventricular rate. So all these data are missing. The only thing is that let's be cautious and let's follow our patient very carefully, not only once every 6 months.
Any other questions? No, thank you very much.